Hello, and welcome back to the Out of Program podcast. Today, we're joined by Dr. Guy Northover, a consultant in Child and Adolescent Psychiatry, the Chief Clinical Information Officer at Berkshire Healthcare NHS Foundation Trust, and the Chair of the Faculty of Child and Adolescent Psychiatry at the Royal College of Psychiatrists. He was the Getting It Right First Time National Clinical Lead for Children and Young People's Mental Health Services from 2021 to 2025, and is now the co-founder of Anathem, an AI startup automating administrative tasks for frontline mental health workers. Hi, Guy. That was quite a mouthful. Welcome to the show.
Hi, Jane. Thank you very much. I'm never too sure when I get introduced whether I should be proud of all of my titles or whether I should be embarrassed by it. But at least I always get some pleasure from the fact that whoever's introducing me finds it a little bit more difficult.
Yeah, I mean, it's very impressive and quite a tongue twister, it must be said. But let's dive straight in and start with your early career. So what drew you to child and adolescent psychiatry, and what were those early years like?
Yeah, well, you know what? I didn't actually start my medical career thinking that I'd be a child and adolescent psychiatrist. I actually started off planning to become an accident and emergency consultant. So my first SHO jobs were in accident and emergency. But to be honest with you, it didn't take me long to realize that was probably not the career for me. I was getting into trouble for spending too long with patients and not having enough throughput through the department. And at that time, the A&E department I was working in didn't have an associated child and adolescent mental health service. So I was seeing young people presenting in crises. I was talking to them and trying to support them, and then having nowhere to refer them on to. And it just became more and more of an issue for me. I started thinking to myself, is this the area I want to go into? Is this what I want to do to try and change the quality of care we get for a whole population and not just looking at the single person in front of me? So actually what I did at that point is I took some time out. I took a step back. I spoke to the local mental health trust to see whether they would have any opportunities for me to join their rotation. I bought myself a Land Rover and I drove down to Ghana. And
Oh, wow.
yeah, and the Land Rover was older than me. So in doing so, it just gave me some time to reflect and think about what do I want to do? Where do I feel I'm going to be able to make the most difference? And on coming back, I went straight into a child and adolescent training post.
And was there anything surprising about working with young people during the mental health crisis?
It's incredible how resilient young people are. And I think that's something which continuously comes back and shows me that this is a partnership when we're working with young people. We're not there to be telling them what to do. It's how can we support them with their resilience to take the next steps that actually most of the time they know they want to do and they know what it is already. So it's just a fantastic opportunity to work with them.
You've spent over a decade at Berkshire Healthcare NHS Foundation Trust now. So early on, did you find that you were drawn to interests beyond clinical care?
Yeah, I mean, I actually became a clinical director 2 years after being a consultant. So straight away for me, the aim of being a doctor is not just about that patient in front of me, as I mentioned earlier. It's how do we drive the quality of care for the community? And that's something that has always interested me and driven my directions of travel. And actually, I was really lucky because my first clinical director post was for a locality rather than for a speciality. So I was clinical director for not just child and adolescent mental health. I was a clinical director for all mental health services within the locality and actually all community health physical services. So I was being a clinical director for a walk-in centre, for example, and for health visiting. So being able to see all these different areas of healthcare and how they all affected each other had a significant impact on the direction that I wanted to take. From that point, I realized that there's no point specializing in a single area because that might make you a specialist in one area, but that doesn't allow you to have such a holistic view to really change the care and the outcomes for the people in front of you. Despite that, I'm still a child and adolescent psychiatrist at heart. So wherever I go, I'm always going to be a child and adolescent psychiatrist.
And then what sparked your interest in health informatics and digital transformation?
It's almost embarrassing, actually. So after my clinical director role, I was promoted into a lead clinical director role, where I was managing 7 clinical directors across the 7 localities. And then one of the clinical directors retired, and pretty much the last thing that they said to me before handing over their badge was, "Oh, by the way, did you know that I've also been the Trust's Chief Clinical Information Officer?" Since I'd been managing them for 2 or 3 years and didn't know that, showed how seriously they had actually taken the role. But then I was in this situation of having to recruit into a post that I knew nothing about. So rather than recruiting the wrong person, I thought, I'll take a step back. I will do this role myself so I understand what it's like, so I understand what sort of person needs to fill it and what sort of skills they need. And within approximately 5 minutes of doing the role, I just realized it was fantastic. It brought everything together that I'd been working towards. It had the holistic approach. It wasn't just about a single service. It wasn't just about one patient in front of you. It was about everybody. It wasn't about standing still. It was about the future. And it was about quality and effectiveness. And the more I did it, the more I realized that there was no way that I was going to give up that role. So instead, I incorporated it into my lead clinical director role and, yeah, never looked back.
And how did you find juggling all these overlapping but distinct responsibilities? Because often guests will talk about how leadership roles are thrusted upon them unexpectedly and then they grow into them. It sounded like you were quite enthusiastic in exploring all those different opportunities, some of which in parallel. So, how was that for you in practical terms?
Well, one of the ways that I look at my life and my work is, if you take on a new responsibility in a new role, if you're doing it well, you should be able to incorporate it into everything that you're doing, and you should be able to drive your own efficiencies. So actually, you're still taking on the role, and after a few months, you're doing it within the same amount of time you're doing your previous role. And almost everything that I end up doing has synergies. So when you think about the clinical director role, and you're assuring the quality and safety of services, that's very similar to the CCIO role, where you're assuring the quality and safety of digital systems. And now we know that there is no clinical service that is done which doesn't have a digital system attached to it, that you can do both of those roles together in a much shorter period of time than 2 people doing those roles separately. So for me, it's always about looking for those synergies, bringing them together, finding out how I can save time and do the job better. And from a leadership perspective, I've never looked for leadership roles, but leadership roles are things that I find enjoyable. All the way back to medical school, setting up a turf club and buying a racehorse for the medical school. That was a leadership role, which at the time I didn't see as a leadership role. I saw it as just a club, but it's how you take yourself through these opportunities and how they become leadership opportunities rather than a non-leadership opportunity.
Because essentially some of those early experiences then shape your later thinking. And what you won't have realized at the time is that you're developing all these skills that then you apply in a different setting down the line. And it may not be immediately obvious at the time how these things connect up together. But I certainly think that's a very common theme of the guests that we bring on to the show. Um, I mean, that was a very interesting story about your time in medical school. So I have to go back and ask, were there any early entrepreneurial experiences during your time as a student or in your early career? Because, of course, you later went on to found Anathem, which we'll touch upon later. But I'm curious to know if that entrepreneurial spark was there from the beginning.
I think there's always been a driving myself spark. But when we come on and talk about Anathem, I probably came into Anathem for slightly different reasons to what most entrepreneurs move into becoming co-founders of startups. Because for me, and I know we'll come on to this later, but Anathem has been a progression of where I've been going. And it's been about how I can actually continue to drive my vision, how I can continue to drive the quality of care for not just communities now, but for the whole country. And if Anathem's successful enough, more than just one country. But the desire to drive myself has always been there. So right back at school, I did an awful lot of sailing, and I'd drive myself to sailing at a very competitive level. I've always been a cross-country runner, which again I think is one of those sports where you end up driving yourself quite a lot because you have to drive yourself through quite a lot of the pain barrier to achieve what you want to achieve. just even going to medical school and going through medical school, I think that does take a drive in itself. So the drive is there. The entrepreneurial spirit, maybe, but maybe it's just come out in different ways.
Fair enough. Let's talk a little bit about your role as Chief Clinical Information Officer. Now, Berkshire Healthcare became one of only 7 mental health trusts in England to achieve the global digital exemplar status in 2017 and during your tenure as well. So can you talk a little bit about that? How you supported that journey and what that role looks like?
It's an incredible role to have as a CCIO, because it's a role that allows you to drive every aspect of an organization. So you do have to think about all of the staff. You're not just thinking about the clinical staff, you're thinking about the non-clinical staff. You have to think outside the box. If you're just thinking from a financial perspective as a CCIO, what you do is you give everybody a notebook and pen, because that's the cheapest option, but it's not going to drive the quality. Within Berkshire, we've always tried to do the opposite, which is actually, okay, what would we do if we had all the money in the world? And how do we achieve close to that with what we've actually got? And that allowed us to be in an exceptionally strong place before COVID. So every clinician was already, or pretty much every clinician was already able to remotely work. Pretty much every back office staff was already able to remotely work. We'd already progressed ourselves as an organization to have almost all of our health informatics systems supported within the cloud rather than within a physical base. So when COVID hit and the request to work from home came along, it was so simple. He was saying to staff, okay, you take your laptop and go work from home. And there wasn't any issues or problems. Every staff had Teams, and off we went. We had to develop some policies, but again, these policies were not too difficult to develop because we'd already been thinking about this. So the working from home policy didn't take very long because we'd already got our remote working policy. So it was just an expansion of where we already were. One of the things that we did learn through COVID was being able to work from home so quickly and so easily also had its downsides. So how could we take our learning through COVID to make sure that we were continuing to support staff? So, for example, at the time I was a senior clinical leader, as still the lead clinical director. I was chief clinical information officer. My GIRFT work was in full swing. I was working for NHS England. I was on call for NHS England and for the trust on some occasions. And working from home meant that for some days I wouldn't leave my office. I'd be sleeping in my office because I didn't want to disturb the rest of the family. And of course, that's not healthy, and that's not something that happens if you actually work out of an office. So we had to think very carefully moving forward, how do we make sure that working from home occurs in the right situations for the right times and the right environments? And how do we make sure that coming into the office, seeing patients face to face, is done correctly as well? So we also were able to bring staff back and see patients face to face quicker than a lot of organizations around us.
I mean, that's really impressive that you already had the infrastructure and set up for the pandemic, because for many of the organizations that we worked with, from a Patrick perspective, we were brought in urgently in terms of digital readiness for deploying of workforce during that challenging time. I wanted to ask as well, in your time as CCIO, what are the things that you are proudest of? And what are the most innovative solutions you feel you've brought into the organization?
Gosh. So I'd say there's 2 things which I'm really proud of, which are quite different. So the first one is a moderated social media platform called Sharon, which we developed in-house to support patients with eating disorders. So we're giving them the opportunity to have anonymous conversations in this moderated platform where we'd have experts coming to speak, to put information, and to really support this community. We had some fantastic success from it. So for a very, very long time, we were the trust that had the least number of admissions for adult eating disorder patients. And we were then
Wow.
able to expand this as an offer beyond just eating disorder services into most of our child and adolescent mental health services, and particularly around neurodiversity. And we did this, and we'd started this before social media became social media as we know it now. So it was innovative at the time, but we've been able to keep it going and keep it safe. and really just do something which is innovative and has become best practice. So that's been fantastic to do. I also had to learn a lot about how you provide safety for a service that you're providing, not just to yourself as an organization, but you're trying to provide to other organizations. So that was a great learning experience. The other thing I'm really proud of is our use of Power BI. I'm I'm not the world's biggest Microsoft fan. We can't really get away from using Microsoft, but being able to have training programs within our organization that are not just about how you use software and how you use the digital tools, but how do we skill people up to develop their own digital tools? How do we give our fantastic staff that ability to do what they want to do? And we've done that with Power BI. And when I start looking now at software such as Lovable, I'm a bit in love with Lovable, I'm afraid.
You and me both.
But when I look at the software which is out there now and how easy it is to create something new and fantastic just from the imagination without having to have all of these programming skills, I think because we really pushed out with Power BI, that we can do this with other software as it develops, and we can turn all of our clinicians into innovators. And then through that innovation, we can really start driving the quality because the people who are doing the work are those who are telling us what needs to be done. We're not there yet, but we will get there.
I mean, I can see where your imagination is going with this, because with an incredible data warehouse platform, you can build all kinds of front ends and applications with AI tools like Lovable. So I can absolutely see your vision. But I think that gets me on to a nice follow-on, which is, what have been the biggest challenges in bringing this digital transformation in a mental health setting? Because it can't be easy.
There are absolutely challenges. It's a hurdle, not a challenge. But I'd say the biggest hurdle is mental health is a small part of the NHS. And when you have innovators, they generally don't want to look at mental health, particularly not NHS mental health services, because looking at the large acute hospitals or general practice is a much, much more profitable place to start. So we find often in mental health that what's been developed for an acute hospital or an acute setting or a primary care setting is transferred and changed to work within the mental health setting. So we then have a product that works, but doesn't necessarily work perfectly for the environment we then put it in. So that's one of the challenges, because you have to use the best that you've got. You've got to train staff in a slightly different way. You've got to put workarounds in, so it's more difficult for it to be adopted by those staff in the first place. Having said that, if we look at electronic patient records, every mental health trust in the country was using an electronic patient record before every acute hospital was using one, despite the fact that the acute hospitals had a centralized resource and funding to implement electronic patient records, and the mental health trusts didn't. So it's not that the mental health isn't willing to pick it up, it's just often it's not there in the easy way. So that's been our past challenge. Interestingly, our future challenge is the opposite. So we now have everybody and their dog who believes they can develop an app which is going to solve the depression crisis or the anxiety crisis or the low mood crisis or whatever mental health crisis is that's out there. And they can develop it using my great friend Lovable in not too long a period of time, and then pop it onto the App Store. So there's this challenge that we have so much out there now, that understanding what really works and what are those fantastic technologies that drive improved outcomes, and what are those technologies which have been developed with skill and love, but don't necessarily have what I describe as the domain expertise to really drive the outcomes that we would want to see.
I can absolutely see that. I want to talk a bit about your national roles. So in 2021, you were appointed as the Getting It Right First Time Clinical Lead for Children and Young People's Mental Health Services. Do you want to talk a little bit about that and about your work? And maybe for the benefit of the audience, explain what Getting It Right First Time, or GIRFT, is?
Yeah. When GIRFT first came out, it was again, it was for acute hospitals, driven by a fantastic charismatic man, Professor Tim Briggs, somebody I have to say I had a real pleasure having one-to-ones with him. But he was an orthopedic surgeon who recognized that across the country, people were doing hip operations differently. They were using different implants and they were getting different outcomes. But nobody had ever tried to look at this data at a national level to understand, is there a better way to do this? So that's what he put forward as a project. Let's collect all this data. It's there. We just haven't looked at it. Let's see where the variation is. And let's identify where things are going really well and what they're doing and how we can share that practice across the whole of the country. And the amount of money that he saved was huge. The reduction in waiting times was huge. And the improved patient outcomes was huge. So based on that, this was a project that then expanded beyond orthopedic surgery across the acute hospitals. And then there was this question of, should we start going beyond acute hospitals? Should we go into primary care? Should we go into mental health? And then another Tim, Professor Tim Kendall, who was the National Clinical Director for Mental Health at the time, was able to say, look, mental health is a prime place to look at this too. We have loads of data. We don't really interpret it very well. And we know that we have massive variation. So Professor Tim Briggs and Professor Tim Kendall got together. They said, okay, let's do mental health. And they started 3 projects. One of them was child and adolescent mental health crisis care. One was adult community health care. And the final one was adult rehabilitation. And it just fitted in very, very nicely with my view of the world, which is how can we actually improve the quality of care using information, data, and potentially technology. And it gave me the opportunity to think about things not just on a local level, but on a national level. So I applied and I got the job.
Very good. Very good. I was just about to ask how it came about, but I imagine you would have been a very strong candidate given your wide variety of leadership and also digital roles as well.
Yes. And also quality improvement at that time. So within Berkshire Healthcare, we'd started our journey down quality improvement. I was the clinical lead for the trust for our quality improvement program. So beginning to get that understanding of waste and data. So we took that forward within the crisis and inpatient services within child and adolescent mental health. As you know, massive variation. At that time, young people were traveling 200 to 300 miles to go to an inpatient unit. And the issues and the problems were not complicated. It just needed to be identified and pointed out.
And in 2022, you authored a report based on your findings. So can you talk me through that and what the long-term outcomes of that report were?
Yeah, I mean, so in a nutshell, I'd say what the findings showed is we don't know who we are admitting into inpatient units. We don't know what care we're providing them. And we don't know if there's any benefit. So it was actually fairly damning when you pulled the report apart and looked at what was underlying it. What we did find is that there were some areas that were doing exceptionally well, and it didn't matter on the cost. So there were just some areas seemed to be able to keep their young people locally, have shorter inpatient admissions, and less restraint and less interventions and better outcomes. So I think one of the greatest benefits of the GIRFT work was challenging systems to say, you may be sitting here thinking you can do nothing, but actually, why don't you look over there? Because they're a system that are very similar to yours, and they are getting better outcomes. And since the GIRFT report, the number of young people who are admitted in a year has halved. So that is absolutely fantastic to see. And now the whole concept and idea of what a CAMHS inpatient bed is starting to shift and change. So for too long, it's been about containing somebody when the risk is too high in the community. And now the shift is towards actually, where is the right place for this young person to get better? Does that need to be a day hospital? Does that need to be a home treatment team? Does that need to be an intensive support team? Does that need to be an inpatient unit? And that is slowly but surely transforming this. So we don't see the young people admitted a long way out of area anymore. It's brilliant. Jing, I'd love to take all the credit for this, but I probably can't. Yes. I think I was one part of it. I mean, one person I should always mention about this is Professor Pratibha Chittsabeeson, who's the National Clinical Director for Children and Young People's Mental Health. And she was the National Clinical Lead at the time of the GIRFT report, and she's continued to take this forward and really push it. And there's a new GIRFT lead as well, who again has been pushing this and taking the work not just from the inpatient units and the crisis services into the community teams. So it's more than just me.
Building on the shoulders of giants, I suppose. We now move on to your startup journey. So in 2023, you co-founded Anathem. So can you talk me through how did the idea come about?
So it's a accumulation of all of my thinking and my clinical leadership career. So it's, why are we struggling so much to provide the high quality mental health care that we know not just children, but children and adults need? Why have we got waiting lists that are continuing to grow? I've done this GIRFT report. I've identified areas that need to change, but it's still a struggle to get those changes into place. I've done my local leadership. We know what needs to change, but it's still a struggle. I've done the quality improvement work. We've identified all this waste, but removing that waste is still a struggle. And ultimately, to me, it felt as if I was able to take a step back away from the NHS, look at the issue and the problem in a slightly different way, maybe I'd come up with a different solution that would work better. And maybe, given my technical expertise, I could find some technical solutions. We certainly wouldn't be able to build these technical solutions within the NHS. And then it was quite fortuitous. So fortuitous and also a bit of privilege. And I think that's also something that I've always been very aware of in my life. I've always had privilege, and we can't take privilege away from ourselves, but I think we do have to recognise it when it's there. So I live in a wonderful town on the Thames in Marlow, where the house prices are really quite expensive. My daughter was playing hockey, which again is a sport where you have kit to buy. And as I was watching my daughter play hockey, I met Richard, co-founder of Anathem, and we just started talking about what he was trying to do to reduce harm from sexual exploitation in Scotland. And we just had a conversation over 3 or 4 weeks, watching our children play hockey. And we thought, well, actually, there is something we can do here. We can start reducing the amount of administration. We can start automating aspects of the mental health care in a way that means clinicians can do what they want to do. And that's where the idea was born. And we were then, again, very, very fortunate to meet Ina, who is a technological genius, who has been able to put our thoughts and ideas into reality and take us to where we are now. And now we know we're doing it. So we now have evidence that we can reduce clinical administrative burden by 61%. That's huge. Once you're doing that, everything else starts falling into place. We know that we can collect the data that we need to collect to start driving the understanding of unwarranted variation at a local level and a national level. We don't need clinicians to enter data anymore. We can collect it automatically from the recording of the consultation. We can do all of these things to take us to the next step of care that we really need to get to. And that's where it's always come to for me. This hasn't been about how can I find something that I can sell. This is about how can I find something that's going to drive the quality of care, continue my journey, and continue to hit my visions. My main vision in life really is about how can I drive the quality and effectiveness of mental health services across the country.
And can you walk me through what that startup journey looked like? Because I think what's interesting for me is that most of the guests, most of the peers I speak to are younger, having developed less in their career, and they make the leap on the basis of all the media they consume about entrepreneurship, and it's very kind of youthful and energetic. But I guess in your case, you've already had quite an illustrious career in mental health services, not just as a consultant, but also in various leadership roles. So I imagine that would look significantly differently, but I'd love to hear it from you.
Resilience is so crucial. It really, really is. There have been so many points that I've had to say to myself, is this worth it? Because it is all-consuming to get a startup off the ground, to get it where it is actually not just being a viable company, but being a viable product that's doing what you want it to do. the perseverance and resilience and the belief that this is going to make a difference. And I think I would have really, really struggled that if I was doing this for a financial perspective, because I don't think that the pain of starting a startup is really worth the financial reward. But it is absolutely worth the reward when I start seeing waiting lists drop, when I start seeing the statistics and I start hearing clinicians say to me that actually they're not going to leave the trust anymore because now they're enjoying their work. When clinicians say, I haven't had to work on a Saturday now for 6 months because of Anathem. And those types of messages started coming in quite early. And that's what kept us going and saying, this is really what we need to do. A lot of late nights, and you need a very, very understanding wife.
Duly noted.
Yes.
I suppose from one vibe coder to another, we've had conversations about how non-technical people can now almost right shift into more technical work. And one of the things that we've talked about in the past is the interesting kind of dynamic that you have with your technical co-founder in building the solution. So can you talk me through kind of what that looks like from actual software engineering alongside prompt engineering, as you described it to me?
I've got an ambition and a vision. Ina tells me it's not going to happen, but I've got an ambition and a vision, which is actually if you get the interaction between the clinical prompt engineering and the technical development team, that you don't need large teams anymore. And the way that the software development of, again, things like Lovable are allowing us to work closer and closer together, we can achieve things much, much quicker. So we've been able to remove this tech team barrier. So I can come up with an idea and say, hey, Ina, I would like us to be able to do this when we're developing a prompt. And then I can tap away on Lovable for half an hour and I can show her exactly what I mean. She can then take that code from Lovable and she can say, oh, that's great. You're 85% of the way there, admittedly the easy 85%. And I can now take this and I can incorporate that into what we've already got. So we can develop rapidly and we can develop based on the feedback of the users and by people who've got that domain expertise. And that really, really allows us to deliver in a way that I think other ambient voice companies are not presently able to do.
And you hear a lot about this, about AI native businesses and how they're basically ripping up the script on how software is developed. And it certainly sounds like you've achieved that dynamic, which is incredible. And that gives you some, process power and also some competitive advantages. Now, you mentioned AVTs, ambient voice technologies.
Yeah.
And I wanted to ask you about that because they are, at the time of recording, they're having their moment. There's been the recent framework announcement of which Anathem is part of it. How do you see that landscape and how are you looking to differentiate from your own background?
Firstly, that's the first time I've mentioned ambient voice because I don't see Anathem as an ambient voice solution. Anathem is a quality and productivity tool presently for mental health services, of which ambient voice technology is one part of what we do. And that part has to be done exceptionally well because that's where the majority of the risk lies. But we do the whole pathway. So if you're uploading a letter, how do you get an appropriate summary of that letter? How do you get an identification if there is something in that letter that needs your attention? How does that letter flow into the summary created from the consultation, and how does that lead to the next steps? And then how do you bring all of that into the pathway so the next time that you're seeing the patient, that information is there and you're not starting all the way from the beginning again? Now, what is it that clinicians actually want? Are they after a letter which sounds like their voice, or are they after something standardized that they can then have an assessment of the quality of that assessment? Are the managers going to want something different to the clinicians? So it's all of these questions and all of these options that need to be pulled together. And that's where it comes down to that part about the rapid development and the rapid understanding of what you want. So when somebody turns around and they say to you, thank you very much for the ambient voice part, but what I really want to know is, out of the 500 patients who have been assessed with Anathem for ADHD, how many of them met 6 or more of the DSM-5 criteria for ADHD? And we can tell them that. And I think we're also different because we have come at this from the quality and the effectiveness. We haven't come at this from being an administrative company. So we've never had the legacy software or ideas of what we're doing here is writing letters. My dream is to get rid of letters altogether. You know, there was a situation early on in the life of Anathem where a trust asked us whether we could work within a memory clinic and create the memory clinic reports. We said, yes, of course we can. If you show us a template, we'll get that all up and running. Within about a week of us starting the conversations with the memory clinic, a GP practice got in contact with us and said, oh, do you think you could use Anathem to pull apart these memory clinic letters we get? Because they're so damn long, we don't actually know what's being said in them. So it's like, hang on a second, what we could do here is we could either charge twice for creating the letter and then breaking the letter apart, or we could actually put you in contact with each other and say, why don't you thrash it out and figure out a better way of doing this? Because we're not after the money, we did the second.
That's a great story. Yeah, if there's one thing AI is very good at, is generating a lot of slop, or whatever the equivalent of that is in the various different clinical settings. It's really funny that GP practice would then need the AI to decipher the slop that was generated in the first place. You know, it feels like all the classic memes that you see about this circular kind of AI, you know, with no one actually, you know, applying some critical thinking.
Absolutely.
Now, I want to touch upon, you know, we've gone through your career journey and we've talked about your clinical role, your leadership roles, both in both clinical leadership, but also digital leadership, your national roles as well. And now your journey with Anathem. You're spinning a lot of plates. How do you keep it all ticking over?
It's always a challenge, but it comes back to that belief that I have, which is that if you're doing a job well, you can do it more efficiently. So I use AI tools more than probably anybody else that I know to make my own work more efficient and effective. There's a lot of synergies with what I do as well. I think it's also important to move away from an approach of presenteeism to an approach of outcomes and outputs. So the conversations I have with my trust is, what do you want me to achieve? What are my targets? What does my job plan say I need to achieve? Not what does my job plan say I should be doing every day? And when I take that and I put that across everything that I do, it works. There are some days when my clinical work takes up the entire week. And there are some days when actually my clinical work takes, I don't know, 3 hours. And if I'm not flexible with my time, then I'm not going to be able to achieve any of this. So I think that's a key principle for me. Well, there's 2 key principles there. So it's the flexibility, it's making sure we're outcome based, and it's making sure that you're using every single tool you can to maximize your output. I also find one of the things which helps me a lot is mentoring people, because that makes you stop and think, and you have to reflect on yourself if you're supporting and mentoring someone. And it's often through those mentoring sessions that I'm giving to somebody else that I actually say, oh, actually, this is something that I'm doing that's not driving me. It's not providing me with the outcomes that I want. This is probably the thing that I should be stopping doing.
That's really interesting you say that, because I also do a lot of mentoring myself. And I think one of the reasons I enjoy it is that the advice or the suggestions that I'm providing are also reflected on myself.
Yeah.
And I find that actually very restorative and very thoughtful. And you know, it gets me thinking as well and applying the same lessons that I'm espousing to someone else. So I totally resonate with that.
Yeah. It always challenges you, doesn't it? So it's do what I say, not what I do. Hang on a second, you can't do that if you're mentoring people. No, you're asking people to do what you do, and you have to be able to explain that very, very well. And when I do mentor people, I do let them know that I don't work a 9 to 5 job.
Hmm.
I gain enjoyment out of working well beyond 9 to 5 hours. And that is the way that I do it. But if somebody wanted to follow my career, they would struggle if they wanted to do it 9 to 5.
On the subject of spinning lots of plates in parallel, a question that I get quite often from clinical leaders who are looking to start businesses is the perceived conflict of interest. How do you manage that, given that you are such a prominent leader in psychiatry, but also the founder of a psychiatry domain AI startup?
It's really tough, actually. It is really tough. When I'm thinking about what I would like to do in the future, what my next steps are going to be, one of those next steps is really trying to support the NHS and mental health services as a whole work closer with industry. How do we break down some of those barriers so this conflict of
Mm,
interest doesn't become unusual? Because right now it is unusual. You don't run across many psychiatrists who have a startup. And if you
mm,
do run across psychiatrists who've got a startup, it's usually something that is completely separate to the work
mm,
that they're doing on a day-to-day basis. So I've had to have a lot of conversations in a lot of different arenas. How do we manage this? So, for example, at NHS England level, I am part of a group that's looking at ambient voice technologies and what standards we should be setting for children and young people. Everybody knows that I'm there as a CCIO and as a co-founder of Anathem. I was very clear at the beginning that I would be there to provide support and advice and insights, but if there was any decision making or any editing to reports that are made, that I wouldn't involve myself in that, because that would be getting too close to the line for me,
mhm,
and I have to maintain that level of independence. Within the trust that I work at, we're doing a pilot in the trust of Anathem at the moment, and that's really, really tricky. And actually, I would say that I've probably learned an awful lot on a couple of occasions, treaded far too close to the line of conflict of interest, and have been lucky enough to have senior people within the organisation who are able to have sensible conversations with me
mm, mm,
early on to say, "Hey, Guy, do you want to stop and think about what you're doing there? Yeah, do you think that's something which might be starting to make it more difficult for us to
mhm,
go down a procurement route for Anathem in the future?" So
mm,
having the
mm.
support from the organisation, which is also trying to tread through this path, has been really very, very helpful. But also painful.
That's super insightful, actually. Just reflecting on what you described, because I think that when I left medicine and started patchwork, it was very rare for people to have portfolio careers of this nature. That was part of the motivation for starting this podcast, is because there's been an explosion of interest, and training programs are now far more flexible. But inevitably, people are going to come across these conflicts of interest simply because if you are a specialist in some clinical setting, that lived experience is inevitably going to translate into the innovations that you are producing. And I would hate it if innovators with great ideas shy away from starting things that can make a meaningful national impact because of those perceived fears around IP or around conflict, given their different roles. So I do hope that there are pragmatic viewpoints, and also as well that there are structures in place to protect that. And it sounds like it's far more common than it was
Yeah,
certainly in my time.
yeah. I mean, you are the absolute trailblazer in this area.
Oh,
I'm
no, you're too,
the,
too
you know,
kind.
and things are changing, but they are still very, very difficult. And I think the other thing which is changing is the ability of people who have been working within the NHS for much, much longer to be able to make this shift. And that wouldn't have
Mm,
happened 20 years ago if I was a 50-year-old psychiatrist thinking I would like to get into the tech scene. there wouldn't have been the opportunity to do that. And not just because the technology wasn't there, but because the complexity of the tech scene at that time meant that I wouldn't have been able to get my ossified brain around the new innovations and the new ways of working. So where I think the conflict of interest is going to be particularly tricky is when you have senior decision makers in the NHS who then have conflicts of interest. And it's how you manage that is tricky. But those are the people who you really, really want driving the new technology, because their domain expertise, their experience across many, many different fields means that they know and understand stuff that you can only get with their experience and time.
Absolutely. Absolutely. So to wrap things up, we always ask the question of the advice that you would give to clinicians that are also looking to go on alternative paths. Maybe they're also clinical leaders who are looking to start their own AI startup. So what advice would you give to people in relation to their careers and in choosing to do different things?
First of all, go for it. I think that the first bit of advice is, if you've got an idea, go for it. You know, what's the worst that can happen, particularly when you've got a career to fall back on. So don't think that somebody's done it before. And if somebody has done it before, you're doing it because you think you got a better idea. So that is crucial. So always have the confidence in yourself. It is going to involve taking on more work, and don't go down the route if you think that you're going to be able to do it and not take on more work. I think that's sometimes a tough message, but I think it's the reality of startup life. It's the reality of trying to develop a portfolio career. It's the reality of trying to do something different and innovative. But having said that, always find ways to be effective and efficient. So whilst you're taking on more work, you're not taking on more work because you think that's what it's going to be like forever. You're taking on more work because you've got the confidence in yourself that you're going to shrink the amount of work that you've got. I think that a lot of people stepping into a portfolio career don't have a clear enough vision as to why they're doing it. So I think having your own vision, having your own personal brand, and holding that close to you at all times as well, it doesn't stop you doing different and exciting things, but it allows you to have that focus and that drive. Enjoy yourself and celebrate success. Yeah, and don't stop learning. I think those are key. It is about enjoying yourself, isn't it? And one of the problems is when you've got a lot of things going on, when you're in a fast-moving role, moving from one thing to another, you can sometimes forget to stop and look back and say, "Blimey, hang on a second, we just signed a massive contract." You know, it's like, "Oh, we've signed a massive contract," but sometimes you've got to stop and say, "Yes, we have done that. We've done something really, really great here." And don't stop learning. Yeah, code with Lovable, make films with VO, make music with SoundDraw. Yeah, do everything you can you never thought you could do, because actually right now there's nothing stopping any of us doing anything. God, is that enough advice?
Oh, that's brilliant. It reminds me of what you said about the ossified brain, because I sometimes think that, you know, with all these AI tools, they're overwhelming, but we need to force ourselves to learn. And I think, you know, for someone like yourself that has already reached, you know, certain pinnacles in their career, to not have that as a solidified identity, and to then reinvent yourself almost as a vibe coder and then become a startup entrepreneur is, I think, you know, incredible and quite inspiring, because it's hard enough to get even, you know, regular people to relook at their ways of working. And some of those, certainly in the age of AI, may impact their identities.
Yeah, completely. I also gain enjoyment out of being judges for digital awards in mental health, and seeing the innovation that is out there and the desire to make a change is just fantastic. And sometimes you look at these awards and you think there's some amazing people here, but they just haven't quite had the right level of help and support to push themselves from where they are to where they can absolutely be. We're not short of ideas within the mental health sphere, but we're possibly just short of that little bit of push or that pull to get these people and these ideas where they actually really want to be.
Brilliant. Well, that's all the time we have for today. Thank you so much for joining me, Guy.
Thank you very much. I massively enjoyed it, but maybe that's a bit egocentric to really enjoy talking about yourself.
No, it's been a brilliant conversation. And For those listening, if you like what you hear and want to support the show, please do like and subscribe to us on Apple Podcasts, Spotify, YouTube, or whatever platform you're currently listening to us on. It would mean a lot to me, and it would really help spread the message to others exploring alternative paths. Thanks for joining us, and see you next time. Bye-bye.